Very appreciative to have our guest speaker, Dr. Kumar, the State Dental Director for the California Department of Public Health, here to talk to us about moving California oral health forward. And then next we have Taylor Priestley, Covered California's Deputy Director of our Health Equity and Quality Transformation Division, here to discuss Covered California's role in oral health. And at this point in the meeting, we'll open up the floor for discussion and feedback. Also, please feel free to ask questions along the way if any should come up. Just feel free to speak up with questions or raise your hand, and I can let the speaker know that we have someone that has a question. And then lastly, I will wrap up the meeting with our next steps. So with that, I'll go ahead and hand things over to Elena to review our QDP issuers and enrollment.
Thank you, Tara. Hello, everyone. My name is Elena Wise. I am the Quality Improvement Specialist and the Dental Lead here with the EQT team. So I will walk us through the Covered California Qualified Dental Plan issuers, the dental programs, benefits, and enrollment. And for 2022, the dental plans contracted with Covered California are Liberty, Anthem Blue Cross, Blue Shield, Dental Health Services, Delta Dental, and California Dental Network. The qualified dental plans were first offered in 2016. They offer family dental plans that combine child and adult dental benefits. Adults can enroll without enrolling children into family dental plans, but if a family enrolls one child, they must enroll all children and at least one adult. The QDPs must include pediatric essential health benefits to be certified and offered by Covered California. Advanced premium tax credit cannot be applied, and family dental plans are only available during open enrollment, special enrollment, and after a qualified health plan has been selected. So regulations require an enrollee to purchase a health plan before being able to purchase a family dental plan. The pediatric dental benefits are considered essential health benefits for children under 19. The qualified health plans have embedded dental benefits for children, and all qualified health plans embed pediatric dental benefits in the individual market. Federal regulations require pediatric benefits to be determined by a benchmark plan, and Covered California uses the 2014 Denti-Cal benefit as the benchmark plan. There is a maximum out-of-pocket of $350 per child and $700 for 2 or more children. The actuarial value requirement was dropped by CMS in 2018, but Covered California still uses an AV of 85%, plus or minus 2 to guide benefit designs. And federal ACA permits QHP issuers not to offer children's dental plan benefit if standalone dental plans are also offered. However, all individual market QHPs include pediatric dental benefits, and pediatric dental commonly is offered by QHP issuers subcontract. So this shows the difference between the embedded children's copay and coinsurance plans versus children's benefits in the family copayment and coinsurance dental plans. Covered California has no cost diagnostic and preventative services in dental plans. The embedded dental plan follows a $350 maximum out-of-pocket, while the family dental plan has a $350 maximum out-of-pocket built in the plan design. The adult dental benefits are a voluntary purchase and are considered an essential health benefit. There is no benchmark plan to base benefit design, no maximum out-of-pocket, no financial assistance available. And even with no federal guidance, Covered California offers consumer protections with the adult benefits, including no cost preventative and diagnostic procedures in the family dental plan. There is a waiting period of 6 months for major services before an enrollee can use a dental plan, and a month is waived for each prior month of dental coverage. This shows the difference between the adult copay and coinsurance plans. The copayment plan has no deductible and uses the copayment schedule for members' procedure cost shares. And the coinsurance plan has a $50 individual deductible and uses percentage for member cost shares, such as 20% and 50%. And the deductible for the coinsurance does not apply towards the diagnostic and preventative. And then this chart shows the 2022 enrollment in the qualified dental family plans as of April 1st. We have an enrollment of over 294,000. These enrollments include renewals, open enrollment, special enrollment. And we broke this chart up by issuer name, product type, adult enrollment, which are enrollees that are 19 years old and above, and pediatric enrollment between the ages of 0 and 18. And we have on the far right the percentage of total QDP enrollment. This last chart shows the 2022 Qualified Health Plan pediatric enrollment as of April 1st. We have over 134,000 pediatric QHP enrollees. These are enrollees eligible for embedded dental benefits. We have this also broken up by issuer plan, product type, then the pediatric enrollment, and then the far right is the percentage of pediatric enrollment in QHP. And I know I quickly went through the background and overview. So I am going to open up for questions here. I will pass it to Tara to let us know to let me know if there are any questions or hands raised for this section here.
Sure. Does anyone have any questions for Elena? I'm not seeing any hands raised at this time. So thank you so much, Elena, for going over our current state for QDP issuers and enrollment.
Hey, Tara, I think I see a question in the chat.
Oh, thank you. I was looking for hands. That's helpful. We do have a question. Has QHP enrollment increased over the past few years or remained stable? QDP.
It's increased over the years. Yes.
Thank you, Diane. That's a good question. Thank you. Okay, thank you. While I scroll through, we have a lot of people here today, but I'm not showing any other hands raised. So thank you again, Elena. And Dr. Kumar, thank you so much for attending today and for taking the time to put together a presentation for our work group. I'll go ahead and give you the floor for the next agenda topic.
Thank you. Can you hear me?
Yes.
Yes.
Loud
okay.
and clear.
Thank you. So good morning, everyone. I'm joining from Washington, D.C., so this is afternoon here. I'm going to take about 20 minutes or so to cover some of the key parts of our state oral health plan, some of the activities we are engaged in right now. And we have a grant with local health departments. That's the second cycle starting in July 2022 for a 5-year grant. And it's called Moving California Oral Health Forward. So I'm going to give you some context, and I'm trying to move the slide forward. Okay. So the oral health plan was released in 2018, and it was we had this objective to assess and address oral health disease burden in California because California, you all probably know, had one of the highest rates of dental disease in children. We were ranked in the bottom quartile when it comes to disease burden and in children, and also use of preventive services. In adults, interestingly, when you look at tooth loss, California has one of the best outcomes. It's in the top. And we think it's because of the progress that California has made with respect to tobacco cessation and reducing tobacco use in California. So the other objective at that time was to enhance infrastructure because we didn't have infrastructure at the state and local level to implement some of the community level preventive services. And then, of course, to elevate oral health and health agenda by mobilizing support, utilizing data, research and evaluation, and building partnerships, and then, of course, to institutionalize initiatives. So with that objective in mind, we published the plan. Next slide, please. Okay. So we usually think of four conditions as public health problems. One is tooth decay in children, more specifically young children, periodontal disease and or gum infections, and then tooth loss. And I don't have oropharyngeal cancers here on this particular slide. If you look at the burden, it is compared to some of the other conditions, it is quite significant. For example, when it comes to tooth decay in children, this is the most common chronic childhood disease. Next is asthma, and tooth decay is 5 times more common than asthma. And when it comes to expenditures in children, tooth decay accounts for a large proportion, according to one study that was published in JAMA. Tooth decay expenditures were third compared to when they looked at 20 different conditions. And then, it affects function, learning, especially absenteeism in school. Dental health is one of the main reasons for missing school days. In California, about 40,000 missing school days because of tooth decay problems. And if we want to prevent disease and improve oral health across lifetime, we have to put these children on a lower trajectory of risk. Next slide, please. Okay, so when you look at adults, I realized that in covered California, more adults are insured compared to children. So I have this slide about periodontal disease or gum infection. If you look at the extent of infection in the mouth in a diabetes patient, for example, so the extent of infection can be 2 to 3 times greater than this 2-centimeter foot ulcer. So if a patient has this kind of ulcer in the foot, will be running to a physician offices for treatment, but the same or even larger lesions are present in the mouth, it's not recognized. And if you look at the prevalence, this is all different severities of the problem, and you can see the extent, and also you can see the disparities in the prevalence of periodontal disease in adults. We don't have good data on this at the state levels. We usually don't collect this one because of a lot of problems. Next slide, please. Okay. So I want to bring your attention to this report that was recently released. This is the Oral Health America follow-up to the 2000 Surgeon General's report to look at advances and challenges. And there are 3 calls to action in this report. It's a very lengthy report, 768 pages, very in-depth coverage of all topics related to oral health. And you can look at the call to action. One is policy changes are needed to reduce or eliminate inequities. Because oral diseases are highly prevalent, and also the disparities are profound, so the report calls for policy changes. So I think what they are talking about is coverage in Medicaid and Medicare. Fortunately, in California, we have coverage under the Medicaid program for adults, but nationally, there was some movement about coverage for dental under Medicare, but that didn't happen. And the other one they talk about is dental and other healthcare professionals must work together. So integration of dental and other health systems is critical to improving the overall health of the patients. And unfortunately, when it comes to training, when it comes to reimbursement, dental, and many other things, dental is always separate and distinct from the rest of the body. So that is a huge challenge for us. And then we need to diversify the composition of the nation's oral health professionals, address the costs, and ensure a strong research enterprise. So we also talked about this in our oral health report because the workforce constitution is not, our composition is not congruent with the population characteristics in California. When you look at the representation of minorities in the workforce, it is small, relatively small. Next slide, please. Okay, so we used the Healthy People 2020 framework in our work. We set the, we identify the needs and priority populations. We prioritized children in our health plan, and a lot of focus is on that, mainly because number one, of course, the problem and disparities are profound. Number two is we have very good interventions at the population level in community settings. We have evidence-based recommendations that can make a huge difference. And when it comes to adults, we don't have similar population level interventions. For example, I'll give you community water fluoridation, toothbrushing, and Head Start early care programs, school dental programs. So we don't have similar programs at the population level for adults. And then set targets. So we have objectives. Those are measurable objectives with very specific targets. For example, we want to reduce tooth decay in children from what was then 71% to 56% by 2025. We have similar targets on a number of topic areas. And then find inspiration and practice tools. And that's where we have spent considerable amount of time in the last 3-4 years. Of course, we lost 2.5 years because of COVID. So we are regrouping to promote community level interventions now. Hopefully, we'll be able to get back to schools in July 2022. And then, of course, monitoring national progress. So we have a very good system, surveillance system. We have a plan, it's on our website, about tracking different indicators and monitoring progress over time. Next slide, please. Thank you. So I'm going to then quickly cover some of the goals. We have 5 goals, several objectives. Under each objective, there are several strategies. So basically, goal is our, what we want to see. It's more inspirational. And then we have very specific objectives. Those are measurable. And then we have strategies to achieve those objectives. So the first goal is to improve the oral health of Californians by addressing determinants of health and promoting healthy habits and population-based prevention interventions to attain healthier status in healthy communities. So we want to make California number 1, especially when it comes to children's oral health, because we think we can achieve that in a reasonable amount of time. And in order to do that, we have to address the determinants of health. And those are generally, when we talk about economic stability or poverty, and access to education and quality education, and then healthcare access and quality, and neighborhood and built environment, and lastly, social and community context. So as a program, it's very difficult to address these determinants of health in a public health department because we cannot affect, poverty. And people ask me, what's the best way to address oral health? I'll tell them the best way is to send everybody to college, because if you look at all oral health indicators, those who are college educated, they do much better. But we cannot do a whole lot at that level as a program. But we can take some actions to mitigate the effects of poverty and education and other determinants on oral health. And that's by improving healthcare access and quality. And then there are interventions at the population level, as I said earlier, about community water fluoridation, promoting healthy habits, especially reducing tobacco, improving toothbrushing, or Dr. Paul Glassman calls it as healthy mouth habits. I think something to that. And then reducing sugar-sweetened beverage. These are interventions that we can promote at the community level in order to improve the health status of the population in communities. Next slide, please. Okay. This is about aligning dental health care delivery systems, payment systems, and community programs to support and sustain community clinical linkages for increasing utilization of dental services. So community clinical linkages are mainly to help connect the community and the clinical sectors, as well as some of the other sectors like education sectors, because one of the best examples of community clinical linkage program is school dental programs, whether it is screening or preventive or virtual dental home. That model fits very nicely under this community clinical linkage program. So, but in order to do that, we have to align the dental healthcare delivery systems, payment systems. So one of the things that we want to promote in California is school linked programs, because as we get back to schools with the COVID restrictions, we don't know whether we'll be able to implement school-based programs right away. We have identified 4,625 schools as eligible, meeting the CDC criteria for targeting. So these are elementary schools, and we want to promote school-linked programs in these settings. Many of them already have. For example, Tuolumne County has a program where they screen all 4,000 elementary school children. There are 36 counties in California that are smaller than Tuolumne. And then in San Francisco, for example, where they screen all 4,000 kindergarten children. But the challenge we have is once we identify children, the linkage part. That's why we are promoting the concept of this referral management system using an electronic platform that's currently being used in other programs like home visiting, for example. And First 5 programs use it in many counties. So we want to use a system somewhat similar to that to link children to a source of dental care and then track and monitor the progress. Next slide, please. So here are some of the strategies that we wanted to pursue, and we wanted to capitalize on the Medical Dental Transformation Initiative. And as you probably know, that there are some incentives now for preventive services in the medical dental program. Those are called pay for performance. And there are some robust performance measures to drive delivery system reform in the medical dental program. And also another initiative that we are really interested, at least pilot testing in 1 or 2 counties, that is to incorporate oral health into diabetes management protocols. Like this is part of advanced primary care initiative, you can call it, team-based care, because there is bidirectional relationship between gum infection and diabetes control. And so there is, just like eye care, foot care, we want to make annual dental examination as a recommendation. And to implement that, we need a referral management system, somewhat very similar to what we are talking about in schools. And then, of course, integrate tobacco use cessation counseling and oral cancer assessment. And so in California, you probably know the medical dental program now reimburses for tobacco use cessation counseling in dental offices. So we were really interested in promoting this concept of counseling in dental settings because traditionally dental offices are used to educating, and we know education doesn't work very well for most dental diseases. So we know that tobacco use cessation counseling is an evidence-based strategy recommended by United States Public Health Service, and we wanted to implement that in in dental offices. And now we are also promoting sugar-sweetened beverage counseling in dental setting. It's part of the nutritional counseling, which is all reimbursed by the medical dental program for children 0 to 6. The next one. Next slide, please. Okay, so goal 3 is about collaborating with payers, public health programs, healthcare systems, and other partners to expand infrastructure capacity and payments for supporting prevention and early treatment services. So as I said earlier, the medical dental program has implemented 2 pay for performance initiatives in the CALAIM, as part of the CALAIM initiative. Next slide, please. Okay. So this is about goal 4 is about developing and implementing communication strategies to inform and educate the public, dental care teams, and decision makers about oral health information programs and policy. So public, policymakers, and providers all need to know about oral health information programs and policies so they can provide consistent messages and also coordinate this not only in multiple language for different audiences in various formats. And one of the objectives here was to increase the number of county health departments and FQHC using social media to promote oral health. And another one was to increase the proportion of patients who report that dental care teams give them easy to understand instructions about what to do. So this is about oral health literacy. So we want to increase oral health literacy of the population. And this is about improving providers' ability to communicate so that they can improve the oral health literacy. So we have an initiative right now. I'll talk about it a little bit later. The next slide, please. This is the, these are the strategies about implementing communication strategies to promote and provide resources on how to use social media, and especially about, say, kindergarten oral health assessment is an example, or about reducing sugar-sweetened beverages, or about the tobacco cessation counseling. And then, of course, provide training and resources to improve dental teams' communication with patients. So next slide, please. Okay, so there is some good news in California. So as I said, when we started, we were using the 2004-2005 data, and the prevalence of tooth decay was 71%. And we just completed a survey of California third grade children. We surveyed about 12,000 children across the state, and the prevalence is about 60%. So there's about 10 percentage point decrease in overall experience. So it is, it's very good news. And of course, 1 in 5 kids have untreated tooth decay, and approximately 440,000 children missed at least one school day. And if you look at asthma, it's about half of this one. So between these are the 2 major health problems why children miss schools. And so oral health is on the top of the list. Next slide. So so we compared the two surveys, 2004-5 and 2018-19. So we look at three indicators of tooth decay. One is caries experience, that is whether it is filled or unfilled tooth decay. So it reflects not only current, but also past caries experience. As I said, it decreased by about 10 percentage points. And untreated tooth decay also declined from 29% to 22%. And the prevalence of tooth decay increased from 28 to prevalence of dental sealants. So sealants are one of the most effective interventions to prevent tooth decay, and it's a very good reflection of use of preventive services. So you can see here it increased. So when it comes to tooth decay experience or caries experience, there is profound disparity with respect to race, ethnicity, language spoken, poverty status, and it's the same with untreated tooth decay, but not with dental sealants. So there are no disparities when it comes to sealants by race and ethnicity or by poverty status. And we think some of the policy initiatives implemented and the promotion of use of dental sealants in the medical dental program may have made some difference in the prevalence of sealants, not only in California, but across the country. Next slide, please.
Dr. Kumar, just a quick question on the last slide. Was this for the entire population or for children?
This is children, third grade children. I'm sorry, I didn't clarify that one. So we use third grade children as an index grade because it's very expensive to do these surveys. And we don't have electronic systems. We don't have big data to look at clinical indicators. So this is the only way we can. So we don't have similar data for adults, mainly because conducting these kinds of surveys are very labor intensive and expensive, and there are no congregate settings where we can go and easily screen people. So, and we use across the country, every state conducts these surveys. It's called basic screening surveys, and we can compare across the country. Next slide, please. I don't know how I'm doing with time. Okay. So as I said, here is the data by region, and you see the disparities. In the Bay Area counties, the prevalence was about 45%, and in the Central Valley, it is about 76%. Next slide, please. So this is eliminating disparities is one of our top priorities. And this is an example of our population health prevention framework, where we want to promote traditional clinical prevention in the clinical settings, like fluoride varnish in primary care settings, the CALAM initiative, and the oral health care during pregnancy. And then when it comes to community-wide prevention, community water fluoridation, toothbrushing, Rethink Your Drink campaign, which is we are partnering with the Nutrition Obesity Prevention Branch, and then oral health literacy. And in the middle is where we want to provide clinical preventive services in community settings. And then a good example is school dental program. Next slide, please. So I don't have a good framework yet for adults when it comes to that one. Can you go back to that slide? I want to make a couple of points. So, for example, I said, we want to promote screening in school settings. One way screening for adults can be implemented is, as part of the annual enrollment and annual re-enrollment, one can implement some kind of a self-assessment checklist asking about tobacco use, asking about diabetes status, and then maybe help them to connect to a primary care source. Next slide, please. So this is our toolkit for, excuse me. This is our toolkit for improving oral health literacy in clinical settings. So we partnered with University of Berkeley Health Action Team to develop a guidebook to incorporate oral health literacy principles in dental practices. For example, the use of plain language. And the other one is using visuals and drawings to communicate messages. And the third one using teach back method. And the fourth one is creating friendly environment to encourage people to ask questions about their oral health issues and problems. So we have a toolkit now, and we are in the process of training dentists, dental hygienists, and eventually, we want to train dental assistant as well. And the way we have started is, we're holding sessions, training sessions at meetings like CDA Presents, and also Dental Society meetings, Dental Hygienists Association meetings, and also with FQHC. So we are looking for champions who can implement oral health literacy principles and share their experience with other practitioners. Next slide, please. So that is about, intervention in dental settings to improve oral health literacy. And this is about improving oral health literacy of the public. And this is through, this is a website that Smile California Medical Dental Program has created. There are a lot of resources on this. And, in 2016, they did a study of members about the benefits and their knowledge and attitude, and a couple of things that came up. For example, when it comes to dental sealants, most members were not able to distinguish between sealants and fluoride varnish. And many of them said, they had sealants, but when probed, they didn't, they were actually confused about fluoride one. So there was a large campaign to promote sealant use. And another one, excuse me. So about the benefits, many pregnant women didn't know about the dental benefits. Although they had the medical benefits, they didn't know about the dental benefits, what was covered in their plan. So this website provides, and we are asking our local oral health program. So as part of this initiative, we have funded all 61 local health jurisdictions, and they partner with Smile California to promote, whether it is school, dental visit, like annual dental checkups, kindergarten oral health requirement. So they're partnering with Smile California to promote all these interventions. Next slide, please. Okay, so if you think about oral health, if everybody brushed and if everybody controlled the intake of sugar sweetened beverages, especially sugar sweetened beverages, sugar in general, and then engaged in healthy habits, stopped smoking, and moderate use of alcohol, they can improve the oral health significantly. So we won't have the kind of problems that we have today in California. So in order to promote these, we need to bring together health plans, public health, and also the other sectors and CBOs by promoting these interventions at the community level. Thank you. So I'll be happy to take questions.
Does anyone have any comments or questions?
Hi, I have one question. Thank you so much for this presentation, Dr. Kumar. I was wondering, I know you said like the focus is children because there's like population level interventions available to address oral health in children. I was wondering if you know of any models for intervention at the population level for adults that like we can replicate. I know like reducing like tobacco use and reducing sugar intake, like those are really important, but sometimes, you know, like oral health in adults is kind of like maybe prevention is not possible because disease has already started. And so I was just wondering if there are any models for intervention that you know of that maybe can be replicated.
Great question. Thank you, Rukai. So when it comes to these interventions, we look for guidance from two task forces. One is called the Community Preventive Services Task Force. Those are community level interventions like, say, seatbelt use, community water fluoridation, and school dental programs. Those are recommended by the Guide to Community Preventive Services. They have a process. They use systematic reviews. And it's not only about effectiveness, but also about cost saving. So we use that recommendation. Then on the individual side, we look at recommendations from the United Services Preventive Services Task Force. And so the recommendation there is for promoting fluoride varnish in the primary care setting. So all of them are focused on children. So when it comes to adults, we're looking at promising practices. In other words, evidence developed through implementing programs and policies. And at this time, the CDC, Chronic Disease Center, Oral Health Program has a contract with the National Chronic Disease Program to look at all the interventions available. There are four I can think of. One is tobacco cessation. The second one is sugar sweetened beverage. And the third one is implementing diabetes screening, hypertension screening in dental settings. Because hypertension, Maryland implemented a demonstration program to identify hypertensive patients in the dental setting and then link them to a source of dental care. Similarly, Colorado did something about identifying diabetes patients in the dental setting and linking them to a source of primary care. So there are those kinds of models. And then, of course, we have models in, senior citizen centers, models in nursing homes. But when it comes to adult population, we don't have a similar type of interventions that I can think of.
Thank you so much.
Hi, this is Paul Glassman. I had just a comment. So thanks, Jay, for a great presentation. Just a comment really about the last part of it, which was the report on health literacy. So I've been, thinking a lot about this issue, the framing, which is very common throughout our whole healthcare system, health literacy, and just a couple of comments about it, and then tie it together with other things you were talking about to support what you were saying, which is that health literacy implies that people are illiterate, right? They're illiterate, they don't know stuff, and you got to tell them things. That's what health literacy means. And so that sort of focuses people's attention on the providing of information is the key. So I think providing information, of course, is important, but we know a lot about people's ability to change habits, and it takes much more than information to have people change habits. So, people need ongoing support. They need to be offered suggestions to do some small incremental things and then get some feedback about that and then try something else. And none of that is stuff that can really happen inside of a dental care setting, which I think emphasizes the point you were making that we need to have partnerships. This idea of community engaged oral health systems, I've been using that word, and community linkages, the word you're using, is really critical to actually do the most important thing, which is to have people be able to manage their own disease. And so sort of tie that back into this conversation about covered California, I think, as this work moves forward, it would be important to think about what kind of structures are needed to actually support the adoption of mouth healthy habits in a community linked setting, which is not often where these kind of things take place. So thanks for the ability to add that.
Thank you so much for your comments. Is there anyone else that would like to have the floor, ask a question, provide feedback? Okay. Rick,
looks
I
like
see.
I'm
Yeah,
sorry,
thanks.
there's a question in the chat too when you're done, Tara.
Hey, Dr. Kabar, Rick Crumman, just asking as a parent of an autism spectrum disorder child, not necessarily just from a health plan perspective, but are you folks seeing increased from the goals that you're targeting efforts in order to address the challenges of oral health within the autism spectrum disorder, child population?
No, not specifically. So as part of the, when in public health, we look at population as a whole, not specific subgroups, excuse me. We are working with, Department of Developmental Services, and also in the maternal and child health, maternal, child, and adolescent health program. There is a program called, Children and Children and Youth for Special Healthcare Needs program. It's a federally funded program. So we work closely with them in promoting access to dental care as part of this initiative.
Gotcha. And then in the oral health literacy document, I appreciate that answer. Does it address anything about ASD in there? I asked just scanning the Oral Health in America document. It looked as though like 7% of dentists indicated that they were prepared for managing ASD children. So just curious whether the oral health literacy document for dentists gets
So
into that.
this is about incorporating oral health, literacy principles.
Gotcha.
One is, plain language, not use complex, whether it is caries or periodontal disease. So instead of that, use tooth decay and gum infection, and then use visuals and drawings to communicate. So we're talking about, using oral health literacy principles.
Understood. Gotcha. Thank you so much.
Okay, thank you so much again, Dr. Kumar, for taking time out of your busy schedule to come here and talk with us today. It was a great presentation. Thank you.
Yeah, thank you. Really appreciate it.
Okay, and next we'll hear from Taylor on Covered California's role in oral health.
Thanks very much, Tara. Good morning, everyone. I am a bit under the weather this morning, so won't be joining you on camera, but hoping we're able to continue the discussion. So appreciate the comments and questions, and Dr. Kumar's presentation and Dr. Glassman's comments as well. And we're really hoping to actually spend just a little bit of time diving into some of the elements of the oral health plan that Dr. Kumar previewed, we realized in planning for this month's meeting that we had sort of dived in last month with our focus on health equity and disparities reduction, and very quickly gotten very concrete in those areas. And we realized with this meeting, it might be helpful to set a little bit of context and move beyond even the framework that we had shared last month in kind of our thinking. So following Dr. Kumar's presentation of the statewide oral health plan and the efforts statewide, we wanted to share with this group a little bit specifically how we're thinking about our role in California's oral health, and then ask this group for feedback and suggestions for potential course correction or other thoughts for how to think about our role here. And we're particularly interested in a discussion around our opportunity to, because we participate both as a public purchaser of commercial dental care, but we are also a public entity and a fairly trusted organization for our members and the public, and so are really interested in our potential role to support some of the public and population health goals and strategies as well. So Elena has walked us through the differences in children's and adult dental under the Affordable Care Act and our challenges resulting from dental care not being an essential health benefit under the Affordable Care Act. So we wanted to be clear about some of our constraints and some of the opportunities we have through our dental plan contract in terms of extending some of those consumer protections, some of our opportunities in terms of benefit design, but in looking at some of our strategic priority areas around health promotion and prevention and disparities reduction and advancing care, wanted to hear from this group in terms of what our opportunities might be, also recognizing that our enrollment profile doesn't line up with some of the identified priority populations, particularly kids and pregnant women because of the expanded benefits and eligibility under Medi-Cal. But we do still see some important opportunities for us to align our work with those statewide priorities and approaches. And we do see a lot of overlap between the statewide oral health plan and our goals, principles, and priority areas for the dental plan contract update. So apologies for a very long wind up here. If we go to the next slide, we just wanted to walk through some of the places we see across the goals, objectives, and strategies that we think might serve as guideposts for our work. Again, both in thinking about our dental plan contract, but also thinking about Cover California's role in public and population health. So we've added emphasis here to the text of the goals to emphasize the components that are particularly promising for Covered California. So if you review the report, some of the strategies for Goal 1 might not be a best fit for Covered California, but when we look at the objectives under a goal of improving health of all Californians, we do see some direct opportunities here. As pediatric dental is an essential health benefit, we do have kids enrolled, as Elena walked us through. And also because we offer full scope medical coverage and tobacco cessation is a covered benefit under our medical plans, we do see opportunities here over the potential long term to support this objective and increasingly look at the integration and sort of crossover opportunities. So wanted to pause here and see if there's feedback from this group or suggestions around either these specific objectives as objectives we would try to support or how we should be thinking about our role in oral health improvement.
I don't see any hands raised at this time.
Yeah. Well, we will practice the
I want to make a comment about tobacco cessation counseling. We emphasized it several times, mainly because it is strongly associated with the outcome of periodontal disease treatment and also with tooth loss. We have analyzed, BRFSS data on this one. There is strong association between tobacco use and tooth loss. And, most clinicians will tell you that, the treatment of periodontal disease will not be successful unless tobacco habits are controlled. So that's why we emphasize this, in our plan repeatedly. Thanks.
Thank you. That's helpful. Dr. Glassman.
Yeah, I just wanted to ask a question about if you could say a little bit more about the constraints, and particularly I'm thinking about, the objective 1A on the slide now, reduce the proportion of children with caries. And my belief, which I won't go into lots of detail about now, is that that's going to be impossible to do very much without doing a much better job of bringing oral health services into community settings, particularly schools, preschools, if we're talking about children. And we have lots of, we know how to do this. I think that that's not a question anymore. The problem is there are many policy and payment and workforce scope of practice constraints for us being able to do what we know how to do. And so I'm just wondering, when you talked about the constraints that Covered California has in implementing design of what you offer, if you could say a little bit more about what those constraints are and how they relate to the idea of expanding sort of dental care out of the idea of a dental office and into supporting some of the things Dr. Kumar talked about school-based and school-linked care.
Absolutely. Thanks for the question. So Covered California operates as a public purchaser, meaning we have the authority to select plans both on the health and dental side to offer our qualified health plans and qualified dental plans. And we have some core certification standards for those plan products that are set by the federal government, by the Affordable Care Act and the accompanying regulations. And then based on our authority as a state-based exchange, we are able to and have elected to, at the direction of our board, really move beyond the sort of minimum certification standards for both health and dental products and establish a fairly comprehensive benefit packages on the adult side for dental, where we have that flexibility, and then really set kind of the bar around quality, equity, and requirements on the plans to best meet the needs of California consumers. In terms of limitations, the primary one that we'll talk a lot about, and then I'll come back to kids, is that since the adult dental is not considered an essential health benefit under the Affordable Care Act, we are not able to extend or offer any financial assistance in the purchase of those plans, the standalone dental plans that include adult dental. And actually, at an even more fundamental level, that means that adult dental is not included in the health plan that members buy from us, whereas it is an included benefit for children under the age of 19. So, and then even within services available to children, because we operate as a purchaser, so we contract with plans to offer the dental benefit to kids through the health plan that they're enrolled in. And then as an additional offering, we offer those standalone dental plans. We, at this point, have contract requirements around things like encouraging community involvement, but we have not taken this step of sort of, explicitly stating requirements by contract for our plans to do these sorts of services. And I'm, not, totally sure, and would want to hear from folks in this work group today around, kind of even what that involvement might look like, if that's financial support, if that's, actually working with organizations directly. And then the other kind of limitation, and the reason that we're really interested in this work group and hearing from diverse participants, is we have no direct mechanism with the provider community at all. So we reach the provider community through our dental plan contract. And we are not sort of our own service provider either. So we have not really thought through and don't really have mechanisms to sort of engage directly in the delivery system or in community settings or like school-based programs. Though I will say, as a former Head Start employee who hosted dentists on site in our schools to provide these screenings and then worked with parents trying to navigate their insurance, whether it was Medi-Cal or at the time Healthy Families, I cannot speak highly enough of the practice of bringing the screenings into the school setting. It's absolutely one of the strongest ways to reach kids. But I'm still working through, even after years at Covered California, how we might have a role to play here. Is that helpful, Dr. Glassman? And I see Dr. Kumar.
Yeah. So, so to follow up Dr. Glassman's question, there are no restrictions on where these services can be provided, right? So Covered California will reimburse the plans whether the services are provided in a dental office suite or in a school dental program.
That's another great question for us, an opportunity for us to clarify. So we hold the contract with the dental plan, and then members pay premium directly to the plan. So we do not reimburse. We don't, there's no payment from Covered California to the plan. So we are different from Medi-Cal in that way, that we connect our members to a selection of plans, and then they choose the plan they want to enroll in and pay premiums directly to the plans. And one other note that your question helpfully raises as well that we should clarify is that the scope of benefits on the pediatric side is determined by the applicable state regulator for that dental plan. So largely Department of Managed Healthcare, and in some cases, Department of Insurance.
Thanks.
Dr. Glassman, you're on mute.
Sorry. Yeah, the question is, could Covered California, for example, in deciding what a qualified plan is, require that the plan pay for services, as Dr. Kumar just said, no matter where the delivery site is or whether they were done in person or using telehealth or some of those other kind of mechanisms that now inhibit dental providers from getting into the community? Could you set that up as a requirement for to be considered a qualified plan and then be eligible?
Yeah, the short answer is yes, and we would. That's one of the hopes for the conversation today is to start to hear from our plans, both currently contracted or plans potentially interested, about what that looks like for their operations. My understanding, I think that would be a change, but that's exactly what we're trying to get to, is what are the contract requirements that will best support these goals of improving health.
It seems like those kind of things, plus in your pre-reading slides, it talked about possibility of population-based payments, and and looking at the health of a population, not just the people that actually have services, which is most people in dental care don't. Those would be potential things to explore.
Thank you. I think if we don't have other questions or feedback on this slide, we can move to goal 2, where we will spread our thinking across 2 slides here, as we do see ourselves as fairly uniquely positioned to be able to support alignment of care delivery systems and payment systems. So again, Covered California does not pay directly providers or the plans for services provided to our members. So this is where we are sort of a public entity who is facilitating the offer and enrollment of members into commercial health and dental products. But we do have a direct lever in terms of our contract, which we do need to always balance sort of the rigorousness of our contract with the reality of the price sensitivity of our membership, since we are not able to extend any premium assistance or cost sharing assistance in our plans, and want to make sure that we're also able to offer a selection of plans as well. So those are some of the challenges and the factors that we are balancing as a public purchaser. But we did want to highlight several of the objectives here of Goal 2 that we think our work could support. Again, we do not have a significant proportion of children, but can certainly support these priorities through contract. And we are certainly interested in potentially long-term, but the opportunities, because we do offer full scope health products, around identification and support services for patients with diabetes, both in medical needing access to dental care, or identification in our dental population, and linkages to diabetes management support, and again, around tobacco cessation. Are there thoughts from the group here? Are we headed in the right direction? And also, for if folks are not wanting to come off mute or come on camera, certainly please feel free to use the chat as well. We don't have a formal poll function set up, but happy to take comments in the chat as well.
Hi, this is Monica Montano with CDA. I had a quick question, actually. Looking at these objectives, a lot of them start with increase, decrease, but I'm curious then, is the actual data already collected in order to figure out how to increase engagement of dental providers, how to increase the percentage of children receiving dental sealants? I think that's my first question, is understanding what data is collected and how then you can track the objectives.
Yeah. So we collect data to track the objectives, but we don't track strategies. I mean, in general, we track whether it has been implemented or what are some of the challenges in implementing strategies. But for example, increase the proportion of preventive dental visit in the past year and reduce disparities. There is the National Children's Survey, and that's a source of data. Medical Dental is a source of data. And we have questions in the CHIS, California Health Interview Survey, to track this. And then maps. So we have several ways we can track this. And we put together a plan. It's in the, it's called the California Surveillance System. And it's described how we intend to track all these different indicators.
And so these objectives would not necessarily be specific to a qualified dental plan. This is just objectives for sort of statewide then, regardless delivery system.
Thank you. That's a great question. Not by plan. So, but we try to do this in the medical dental program. So all these, to the extent possible, we try to track in the medical for children's services.
Monica, it's a great question. This is Taylor at Cover California, and we are using the language of the statewide plan, and this is really intended as sort of directional. Like, we don't want to operate in a vacuum and just work from like Covered California thinks here's what we should do. So we are really looking, for alignment opportunities, both at DHCS, as the program administering Medi-Cal Dental, but also really because dental is different and the factors supporting oral health are not limited to dental care. That's where we're also looking at our public health partners to look at what the kind of guideposts and priority areas should be, so that we are not sort of striking out on our own in terms of the contract work. So looking for understanding around opportunities for alignment, both across Medi-Cal as well as the public health perspective. So just as Dr. Kumar is saying, we would not be proposing these as performance standards in a contract, but just are these the right general goals and objectives to pursue?
Okay, no, I definitely appreciate the clarification here, and I think there was just some confusion and sort of laying out the goals and the objectives, understanding that it's not necessarily for the qualified dental plans. And I think the question that I have is, you know, the goal, definitely we support the goal, and I think specifically it's hard to sort of have a conversation about the hypothetical objectives here without really knowing sort of what are we thinking as far as what could be the objectives for the qualified dental plans to really accomplish this goal or reach that goal.
We also have a raised hand from Carolina.
Hi
If you'd
there.
like.
Yeah. So yeah, I really appreciate these objectives here, and also Monica's comments as well. You know, I think one thing that is coming up is really this conversation around sort of the strategies for supporting adult oral health, given that we know, as Dr. Kumar outlined, periodontal disease is very prevalent among that population. And so appreciate the efforts to align with some of DHCS's initiatives. You know, DHCS, as I understand it, had proposed to expand the DTI initiative to adults, at least in terms of incentive payments for preventative care for adults, which we appreciated, but I think saw them as somewhat limited, given that we know periodontal disease or caries is actually in some cases more prevalent among adults than say the child population. And so, you know, I think one thing we would like to see more of is ways to incentivize restorative care or restorative treatment in the case of in the event that periodontal disease or caries is identified as a result of a preventative exam. So, you know, hoping to see more incentives for providers for offering those restorative services to returning patients in that event. So basically some, you know, where can we get some continuity of care for those patients who return to a provider to receive restorative treatment?
Carolina, thank you. It's a great suggestion, and I think also a really helpful example in terms of thinking about Monica's question around, you know, this conversation today is really intended as like first step to corroborate that we're headed in the right direction. So this really follows the framework that we previewed last month, and then of course the really difficult work and the questions we'll come back to this group around are then if we've identified the right priorities and the right objectives, then what are potential contract mechanisms, or again, as we get, you know, more towards goal 4, are there specific activities for Covered California to conduct rather than relying on the dental plan contract. So thanks very much for the suggestion around adults, and also for a great example about where we might go after the conversation today. Goal 2 we did highlight a couple of the strategies, and I think Carolina's comment might be a great segue to the next slide here around the strategies. So we are certainly looking to understand Medi-Cal's work in this area, and certainly, you know, the I guess the silver lining of adult dental not being an essential health benefit is that Covered California has a fair amount of flexibility, again, in that balancing act around cost and participation in setting the benefits package and the benefit design. So we'll definitely take that note around adult restorative and looking for opportunities to incentivize there. And again, coming back to the overlap of diabetes management and dental care, and then tobacco use cessation counseling here. So if we don't have other thoughts on goal 2, we'll pause here, but maybe we're ready to move on to goal 3 as well. Thank you, Elena. So looking at goal 3, another opportunity here. We were looking specifically at our role to play in coverage and payment strategies, and then again, payment policy. So Dr. Glassman noted earlier that we have shared some early concepts under consideration. We're certainly interested in the potential for payment reform and population-based payment to start to support some of these outcomes. I think Carolina makes a really important point about our benefit designs currently really incentivize preventive and diagnostic care at no cost. But what are some opportunities to incentivize or reward activities or payment strategies that encourage members to return for restorative treatment? And we understand this is complicated in dental, and there's a number of things that would really need to shift. But we do see this as a primary opportunity in terms of the mechanisms of benefit design in the dental plan contract. I don't know if there's other thoughts here, either in the objectives we've identified or potential approach.
I don't see any at this time, Taylor.
Oh, yeah, Dr. Glassman.
Yeah, I'll just make one quick comment at the risk of now feeling like I'm talking too much on this session, but whatever. So, the idea of encouraging alternative strategies, it's possible to make some progress doing that with a benefit design of exactly what gets paid for, but there's another aspect to it, which is training and technical assistance and understanding of how to achieve that. I've seen, without going into detail right now, but numbers of incentives that have been set up for improving health, and incentives that would actually increase payments to plan providers, but without the actual know-how of how to actually be the strategies of how to actually be successful. Many times those incentive payments go unclaimed because the provider is just doing things the way they've always done things and doesn't actually have the understanding or the technical ability. So it's again the question about constraints of Covered California. If there was some understanding that Covered California could do something in terms of the qualifications and criteria, but also pair that with some ability to work with health plans in terms of training and technical assistance of how to set up programs that would achieve these goals better. Is that something that Covered California could do, or is that outside the realm of what you were allowed to do?
That's a great point for us to consider going forward, and would certainly, love to hear from both the plans and maybe CDA on this moving forward as well. And again, on the one hand, we can put anything we think is right in the contract, but it is a balancing act, in terms of having plans want to participate with Covered California, and then again, at what price point for our members. So would love to hear from plans around that potential impact. And I think the other thing for us to think through is we can put requirements in a contract, and we can put potential negative consequences for failure to act in a certain way, but maybe we need to also be thinking through incentives or ways to encourage certain activities. We recognize that a lot of these if we were to go down a requirements road, these are in some cases significant investments on the part of a plan with their network. So would want to think through and hear, from maybe from plans and the provider community, especially around practical ways to think through implementation of these ideas.
Yeah. Hi, this is Dan Crowley at Delta. You kind of went where my head was going. Obviously, this will take significant engagement with the provider community, and administratively to get significant adoption across that provider community, it's probably going to be pretty expensive. So I think we need to be careful to weigh that because, as you said, we want to make sure that we head in the right direction, but we don't scare plans away because it's just going to be too costly and cost prohibitive, perhaps within the cost confines of covered California to go in this direction. And then additional, I mean, everything from the outreach to the provider community, as well as just the additional resources necessary to attract appropriately, and the coordination across plans to make sure that we're using the same metrics or incenting similarly might be challenging. Because if there's a variation, then providers won't know what to do. They won't be incented, and the variations will drive a lot of confusion in the provider community.
So I have a comment about this and thinking about the incentive portion here. We do see that this could be a really viable way to increase in positive oral health outcomes when looking at DTI and even now the CalAIM initiative. This has definitely, it's almost like a proof of concept. When there are incentives, we do see increased utilization. We do see positive oral health outcomes. And so I would like us to talk more and explore how that can happen. Of course, with the balance of not having premiums be so high that individuals are then unable to obtain those. But I definitely do want to have us explore that more.
Thank you, Monica. And Dr. Crowley, thanks for your comment and the reminder that one of our core principles for the contracting work is alignment and really wanting to reduce any sort of fracturing or confusion for plans operating in more than one market, and certainly for providers who are trying to respond to multiple contracts across the marketplaces potentially. So that's definitely something we want to keep top of mind. It certainly seems like we'll have plenty of discussion to keep our work group busy in the coming months. And maybe if no other comments on goal 3 here, we'll move to goal 4. And I think this is a place where we really see not just impacts to our dental plan contract, but a potential role for covered California as well. We have a lot of avenues for member communication, for communication with the public. We have a really active social media team of staff that are sharing information and maintaining relationships with our members as well as the public. So I think this was an area as well where we're interested in feedback from the group. And again, not making decisions or commitments today, but are we thinking about this in the right way to think that we might have a role to play, potentially less in the development of these materials, but in the dissemination and supporting the implementation of communication strategies. And maybe, Elaine, it makes sense to move to the next slide, which is the details of strategy 4.4. Thanks very much. I think maybe following up on Dr. Coley's point a moment ago, I think as we get into as we learn more about training and resources that are identified by our partners at public health or potentially at DHCS, there may be this work group or future iteration of it may be that sort of venue to make sure that we're hearing from plans, across the covered California participants, and then potentially with DHCS, like, are we using the same member information, the same health assessments, those kinds of things, and looking for opportunities for alignment and consistency where feasible. Okay, this one is not generating a lot of feedback, which is no problem. Happy to take any thoughts that might occur to folks after today's session. That was the last goal that we wanted to highlight, goal and strategy that we wanted to highlight for feedback. So appreciate the questions, comments, suggestions, and the opportunities to really clarify how we are thinking about this. And look forward to more discussion going forward. I think with that, I'll hand it back to Tara and Elena. Thank you.
Okay, and before I move on to next steps and wrapping up the meeting, do we have any general discussion or comments or questions even on the presentation today?
I just want to comment that really appreciate Covered California putting this together, and definitely very excited about the ongoing conversations around this. I think this will be very robust.
Thank you so much for that note. And thank you so much, everyone, for joining today, this month and last month, and hopefully in future months as we talk through the possible initiatives. And we very much appreciate our guest speakers and the discussion of the group today. So if you have any other questions or comments or feedback, maybe that you wanted to provide more directly to us, please email us at pmdcontractsunit@covered.ca.gov. We'll be monitoring that inbox for any feedback, and we'll get back to you. So next in June, we have for our next QDP issuer model contract refresh work group, we will have an anticipated focus on health promotion and prevention. That will be June 2nd from 10 a.m. to 11:50 a.m. With the materials forthcoming. We'll attach those to the invite as soon as they're available. And before I close, are there any other comments or questions? Okay, not seeing any. I hope everyone has a great rest of their week, and we will be in touch soon. Thank you so much for joining.
Thanks, Tara.
Thank you.